Thank you for the opportunity to present today. We have no conflicts of interest. Colon cancer is the fourth most commonly diagnosed cancer in the United States, with over 1 million people living with colorectal cancer. Staging has generally been done using the T&M classification. Studies have shown a correlation in non-metastatic colorectal cancer between patient survival and immunoprofiling. Regardless of stage, these predict prognosis. The presence of tumor-infiltrating lymphocytes within the tumor center and at the invasive margin create a dynamic microenvironment. Some immune markers that have been looked at in the past include CD3, a marker of mature T cells, CD4, which is expressed on helper T cells and memory T cells, CD45R0, which activates CD4 cells to serve as memory T cells, FOXP3, a regulatory T cell, and CD8, which is expressed on cytotoxic T cells. To study this, in 2006, Galan and colleagues demonstrated that the presence of these tumor-infiltrating lymphocytes were a better predictor of survival than traditional T&M staging in colorectal cancer. He compared the invasive margins and tumor centers separately and together. In figure A, you see the classical T&M staging. In B, you can see how high versus low CD3 stratifies survival better than classic T&M staging. He and his colleagues used this data to develop the Immunoscore system using the cumulative score CD3 and CD8 at the tumor center and invasive margin. They validated this both internally and externally for stages 2 and 3 colorectal cancer patients, confirming its prognostic value. They have also gone on to show the value of Immunoscore in treatment algorithms. Our group evaluated the immune profile in an international prospective multi-center trial of ultrastaging in colorectal cancer, with special attention to both surgical and pathological quality measure. We confirmed CD3 at the tumor center and invasive margin and CD8 in the invasive margin were predictive of disease-free survival. Although immune profile has been evaluated in early stages of colorectal cancer, little is known about its role in more advanced stages, particularly those patients with peritoneal carcinomatosis. These patients typically have a poor survival and very poor quality of life. In 2003, Beerwall and colleagues performed a prospective randomized trial showing that cytoreductive surgery in HIPEC is superior to standard chemotherapy for peritoneal carcinomatosis from colorectal origin. Since then, multiple other studies have shown similar success. Cytoreductive surgery in HIPEC is a complex procedure with the goal of removing all cancer from the abdomen, often with large amount of debulking, taking tissue out from all the quadrants. This procedure is often considered morbid, with about a third of patients suffering a comorbidity as seen in one NSQIP analysis. In the right patient, however, survival can be greater than 5 years. An R0 resection is obtained when there is no microscopic cancer cells left. R1 is when the margins are microscopically positive, but no macroscopic disease is in the abdomen. R2 resections are defined as macroscopic disease left behind. R0 and R1 resections have much better survival than an R2 resection. With the goal of leaving no macroscopic disease, we currently use histology and peritoneal carcinomatosis index for patient selection. The PCI is seen here. The abdomen is broken up into 13 areas, 9 in the abdomen and 4 more in the bowel. A PCI less than 11 is considered low. Surgeons generally use 17 to 20 as the upper cutoff of someone who may not benefit from surgery. This number, however, may be more indicative of the moment when this was diagnosed and not the biology of the disease. The selection of patients for this procedure who are more likely to benefit continues to be challenging, and we therefore wanted to evaluate whether the immune profile is both prognostic and predictive of response to therapy. In this study, we aim to identify whether tumor-infiltrating lymphocyte expression impacts overall survival and disease-free survival in colorectal patients with peritoneal carcinomatosis undergoing cytoreductive surgery in HIPEC. Patients were chosen from a prospectively maintained database. These patients were 18 years or older, had cytoreductive surgery in HIPEC for non-appendiceal colorectal cancer. Additionally, tissue was only taken from the original HIPEC and not any repeat HIPECs. Our pathologist, blinded to all clinical data, examined the slides and chose representative areas at the tumor center and invasive margin. Then a blinded reviewer performed digital analysis afforded quantification of T cell densities within each region using the NIH program ImageJ. Here you can see examples of the invasive margin and tumor center for one patient with the different stainings. The black arrows indicate the invasive margin. There were 66 patients with 80 tissue samples. 14 patients had a primary in addition to their metastatic tissue. Median age is 54, median BMI 26. Most patients were female. About 2/3 had an R0/R1 cytoreduction. Most were low grade, node positive, and had chemotherapy. About half of the patients had a PCI less than 11. Using univariable and multivariable analysis, immune profiling is less representative of prognosis in carcinomatosis than in earlier stages. For overall survival, only the CD3-CD4 ratio is predictive on multivariable analysis. Immune profiling does not predict disease-free survival. When accounting for grade, resection status, and lymph nodes, none of these factors nor the Immunoscore have any predictive value for overall survival. This is in contrast to what has been seen in non-metastatic colon cancer. We were then interested to see if there was a difference in the immune environment between the primary lesions and their corresponding metastases. When comparing these paired groups, multiple factors, CD3 at the invasive margin and tumor center, CD8 at the tumor center, and FOXP3 at the invasive margin were all higher in the primary tissue opposed to the metastasis. The picture on the right is the IM, or the invasive margin of patients' primary and metastatic tissue. We then decided to stratify the patients by low versus high PCI. We chose a PCI score of 11 because a recent French randomized trial, Prognostic 7, compared cytoreduction alone with cytoreduction in HIPEC and found that cytoreduction alone may be adequate in this group, and the addition of HIPEC benefited those with a PCI score of 11 to 15. Little benefit of HIPEC was seen in those patients with a very high PCI score. We found that a higher CD3-CD4 ratio at the invasive margin improves both overall survival and disease-free survival in this low PCI group. In summary, immune profiling is less prognostic in colorectal peritoneal carcinomatosis than in earlier stages. The ratio of CD3 and CD4 at the invasive margin is prognostic for overall survival and disease-free survival in those with a PCI less than 11. Within the same patient, primary tissue had increased tumor-infiltrating lymphocytes compared to the metastatic tissue. Because there were higher tumor-infiltrating lymphocytes in the primary tissue and immune profiling had more of a prognostic impact in low PCI, we believe that a high CD3-CD4 ratio portends a better outcome before the metastatic disease overwhelms the immune system. Regaining control of the immune system may be a therapeutic goal. Patients with a high CD3-CD4 invasive margin ratio are good candidates for cytoreduction and HIPEC. We speculate that they might be a cohort of patients who do not need neoadjuvant chemotherapy. Personalizing the sequence and use of systemic chemotherapy, debulking, intraperitoneal therapy, and targeted therapies based on the status of the peritoneal immune environment needs to be further explored. Thank you for the opportunity to speak.
Very, very well done, Mary, and excellent work to investigate any predictive markers for better patient selection. I don't know, Rick, were you still able to stay on the conference to be able to discuss this as primary? I know that you had indicated that you probably had call duties. Oh, Mary, I have a few comments for you and questions. Fact 4. A lot of us aren't familiar with this J software that you used in your study. So how reproducible is the software package, but across pathologists to really provide a reliable and reproducible Immunoscore, either patient to patient or even within the same patient? My next question is, I'm interested to know how much material you showed, obviously tissue blocks, and obviously this could be arranged with tissue microarray, but could you actually do this with cytology specimens as well, meaning those that would have a liquefied component of malignant ascites? Could you get a cytospun tissue sample to be able to perform an Immunoscore? And does it matter whether you're measuring from one area of the abdominal cavity to another? Is the Immunoscore fairly reliable within patients? Also, if you can just expand a little further, I think to take this to the next level, those of us who do cytoreductive surgery would be most interested in just doing a portion of the sampling and trying to establish an immunoscore that would be reliable for a patient without having to address it in the primary site of disease. As your data has pointed out, there is some variability at the invasive margin between the primary and metastatic sites. But obviously the metastatic sites are most easily sampled almost in a laparoscopic kind of preoperative or pre-cytoreductive surgery phase. That we could use that as a prognostic marker. I think a lot of us could see doing a staging laparoscopy to obtain tissue for doing immunoscores, but we would probably want to stay away from actually taking out the primary during that staging laparoscopy.
So to start your questions, ImageJ has been created by the NIH. I know previous fellows at my institution have used it as well as myself. I think that there definitely is some subjectivity to this particular project, both with having the pathologist kind of pick the most representative area on the slides, as well as how you run the program, because you do have to kind of, it takes the whole sheet and does a consistent density score, but sometimes there's smudging and you have to take that part out and do the math to fix that, which obviously makes it a little bit more subjective, and we try to have the best possible slides, but a lot of these patients were from 10, 15 years ago, and the slides unfortunately are not perfect. The second question about cytology, I think that would be very interesting. I'm not sure how easy it would be to do, especially because these scores have been mostly validated by using a combination of the tumor infiltrating lymphocytes at the tumor center and the invasive margin. So it would have to be revalidated to see how useful that particular mechanism of getting cells is. And finally, which is what I think is most important kind of clinically looking at this, is that one, I think that unfortunately I would really hoped, and even when we'd only gone through like 30 patients, it looked like the immune score might be more exciting even in peritoneal carcinomatosis. And unfortunately, it looks like it's not as useful as some earlier stages. And so I think one, a diagnostic laparoscopy in these patients is extremely important to figure out the PCI score, and I think you could get a metastatic lesion, which is going to be more indicative, I believe, of their prognosis, because you can see how much the body is still trying to fight off the metastases as opposed to the primary where it's really centered. Where I think that this is all heading is that eventually for these patients, we would go in and do a diagnostic laparoscopy, look at the PCI score, get some metastatic tissue, hopefully something easy off the peritoneum, and be able to run both immune scores and genetics on these. And I think that it would be really interesting to see in different patients how we can change the timing of things. I think there are some patients who I think debulking up front before chemotherapy could be really helpful. Whereas other patients, I think that chemotherapy might help gain control of some of the disease and allow your immune system to kind of reactivate and then taking them to surgery. So, and that's all just me thinking, and that would have to be validated, but I think that's where we're headed.
Right. Very well done, Mary. And as you pointed out, that good outcomes, particularly with oncologic surgery, follow very good patient selection parameters.